welcome here. In this Congress, we have 4 different panel will be here. The first one is our panel, and the title of our panel is Personalized ART Cycle Management in Global Perspective. We have 5 panelists, 3 of them from our country, 2 of them from outside of Turkey. It's well known, Dr. Orvieto from Tel Aviv, Israel, and Meseguer from Spain, Valencia, Ive. And from Turkey, we have 3 distinguished speakers, and our lady is Dr. Ümit İnceboz from Izmir. She's working on the private practice, and Dr. Kubilay Vicdan, he is working at the private practice at Ankara, and Dr. Ercan Baştu, he is working at the Istanbul Medical Faculty. Actually, we have 90 minutes, and we have to speak a lot of questions. We have to discuss it. We prepared some questions about the 4 different classes: approach to couple, management of the ovarian stimulation, lab techniques, and the last one, embryo transfer. I just sent a couple of questions to the panelists, and they prepare for these questions, and they have got some slides. If we need, we will use that slides. Thank you for coming, us. And we will start with the approach to the couple. And the first one that I sent you, which is very important, how can we manage with the patients with unexplained infertility? Actually, please reply with the quick answer. It's important, and from literature and from your own business. And the problem for the uninfertile couple people, the problem, we have to do intrauterine insemination or directly IVF, which is very popular nowadays. Okay, we will start with Dr. Raoul Orvieto.
So we're speaking about the approach to unexplained infertility.
Yes.
So actually what we are doing in the first cycle, we are offering them the antagonist protocol so we can substitute the HCG with GnRH agonists in case where there are a hyper response. And
you will start with IVF? You will start with IVF?
No, you are starting with ovulation induction,
okay.
But after 3 to 6 failed cycle with ovulation induction and IUI, that's what we are offering them. We are then proceed to IVF, and in IVF case, we offer them the GnRH antagonist protocol, so that if they will hyper-response, we can always substitute the HCG with GnRH agonist trigger. And regarding ICSI or IVF, we're actually splitting the oocytes, and some of them we are doing ICSI, and some of them we are doing IVF, and that's because there is actually some kind of 10% total fertilization rates in case of IVF to unexplained infertile couples, and we don't want to say, okay, no transfer, let's go in the next cycle to ICSI. So actually splitting the oocytes half to IVF and half to ICSI.
As I understand from your practice, only first you are using the IUI cycles for this couple, right?
IUI with gonadotropin, not clomiphene.
Gonadotropin. How many cycles?
3 to 6. 3 to 6 cycles.
3 to 6, okay. How about the patient's age? Is it important or not? Under age 30 or age 35, the patient's woman's age?
Probably under the age of 35, we'll go more to the 6 cycles, and over 35, we do no more than 3. And in Israel, we are allowed, if a couple, if the patient is 39 years old or over, so we can start from the first cycle to do IVF. Okay. And it will be subsidized.
Okay.
Unexplained infertile women, and if the woman is more than 39, so the first gonadotropin that she will get, in Israel, she can start to do it in IVF.
Okay. Ümit?
Okay, when we are talking about unexplained infertility, we should definitely consider the age of the patient and the duration of the infertility period, as well as sperm parameters. We definitely should consider total motile sperm count. It should be above 5 million in That's what we are doing in our practice. Right, and that's basically what we do. If the age is above 38, then we should definitely discuss with the patient in terms of the success and the duration. If the duration is more than 4 years, again we have to discuss with the patient, because the success of IUI is not very good if the duration is more than 4 years. If total motile sperm count is less than 5, definitely we offer IVF, not an IUI. And how many cycles for your question, not more than 3 in our unit. That's what we are doing. Okay.
Kubilay. Bize tekrar mikrofon lazım. Mikrofon getirir misiniz?
First, I am sorry for my voice. I have flu. Maybe we have to look another perspective in the IVF era, because, of course, the age of the patient is important, duration of infertility is very important, and maybe we have to first carry by IUI. But when we look at the past studies, nearly 40 years, there is no change in the success rate of IUI. And by CC IUI, it is about 7 to 10% maybe. By adding the gonadotropins, it increased to 12% maybe. And now IVF is less expensive, and the success rate increased nearly 40 to 50% in per cycle. So maybe we have to first discuss wait expectantly, thereafter go direct IVF, or we have to provide some IUI cycles. It must be discussed.
Ercan.
First, I want to explain unexplained infertility. The main issue is the age. The pivotal thing is the age. Under 35, we can follow different pathways. According to 2013 NICE guideline, they offer, after waiting 2 years with any other problems, you can go directly to the IVF in unexplained infertility. And also there is a study which they call FAST trial. They also tell that you can bypass the gonadotropin IUI cycle to directly IVF if you started CC IUI. In our main practice, we consider the age and other ovarian surgery reserve tests and BMI as well, and then we offer them 2 gonadotropin IUI, and then we will consider IVF.
Orvieto, you know the NICE guideline, they say, please do it in this couple, please do it IVF directly instead of the IUI.
In 39 and more. I think that the question is in which environment you are practicing and who is paying for IVF. This is the question. Because if IVF is subsidized, so if you will do, and we know that the outcome at the end of the day with IVF is the best, so you can do IVF and transferring one embryo so we will prevent multiples. That will be the best way to achieve the best outcome. But if the IVF is not subsidized, in our country it's subsidized, but you can do directly IVF because they won't pay for it. They pay for it only if they fail 3 IUI cycles. So actually, depend if you are considering the patient and who is paying. And the environment, that's what will, at the end, will decide what you are going to do.
When you discuss it at the couple, in your practice, Orvieto, how is your percentage rate for the success of the IUI cycle?
What is
your success rate?
It's about 10 to 15%.
In unexplained infertility, 10
yes.
to?
Up
15.
to 38 years
10
old,
15,
yes.
okay.
Unexplained. We are speaking about unexplained.
Yes,
normal
unexplained.
sperm analysis,
Yes,
normal,
unexplained,
it's
yes.
not 5 million.
Yes.
Unexplained.
You say 10 to 15, right?
10 to
the
15,
couple.
yes.
Okay.
But again, we have also 15% of multiples because we are actually stimulating the patient and aiming to get 2 to 4 leading follicles. That's our regulation, up to 4 follicles more than 50 millimeter in diameter. And if you have more, you have to stop to cancel the cycle. So if your aim is to stimulate to 4 follicles, so you will have also about 20% multiple pregnancies. So that's the problem. And if you want to avoid it, so you go back to all the Gleicher publication, I think it was even in the New England, showing that if you want to prevent multiple pregnancies, so embark all the patients to IVF and transfer a single embryo.
For the
And
IVF,
today, with all the vitrification success, that you are actually not missing or discarding any embryos, so the cumulative pregnancy rate will be the best if you do IVF, transfer one fresh, and then one by one the frozen, and you will get the best pregnancy rate. And it was recently published by the Bristol group, showing that the cumulative of fresh plus frozen, the more oocytes, the best outcome.
Margus, when you do the at laboratory, do you see special things for this couple, for the oocyte or for the sperm? They say, clinicians say to you, this is unexplained infertility, clinician diagnosis. You are doing IVF procedure, you are doing ICSI procedure. In your practice, do you see the special things for the unexplained infertility couples?
Like Raoul was talking, I mean, we are talking about unexplained, so we don't need to think about the age, because if not, we'll be advancing maternal age. So the logical approach that we do, and mostly many clinics do, is, and I'm agree also that the environment also is conditioning the cycles, because it's not the same if the patient is paying or is paid by the government on the regulations. But normally the first approach is the IUI, okay? And normally in those patients also we don't see any effect on the sperm quality. So we normally do not think in any special test for those patients, apart from the standard sperm analysis, just to check concentration, motility, etc. The initial approach is to doing 4 IUI, and if these 4 IUI fail, then we move to IVF. Normally when it's a failure of IUI, we decide to do mixed IVF ICSI. So 50% of the oocytes are IVF, 50% ICSI, because we do not need to.
You do half-half, right?
Half-half, to discard if there is a problem also with the fertilization by itself. So that's the initial approach. Any special treatment, any special selection or whatever, because apparently are the patients with the better expected outcome.
For the audience, she is 32 years old. Her AMH level is 2.2 and 3 years marriage. Will you do IUI? Please, could you raise up your hands? Just do it IUI or just do it IVF procedure directly? Who prefer just IUI for this patient? Could you raise your hands? 32 years old, 2 years marriage, AMH level 2.2, IUI. How about IVF? Who prefer to IVF for this patient? Just a few. Okay, thank you. And the next question, patients with hydrosalpinx, and she has hydrosalpinx, unilateral or bilateral hydrosalpinx. Ercan, what is your approach for this patient? Mono or bilateral?
If she has a hydrosalpinx, we, of course, definitely we need to cut its relation with the uterus, with the endometrium. Especially if she has just one hydrosalpinx and the other tube is normal, we just perform the one side. If it's both sides, of course, both sides, we will ligate them. And if it's possible, we remove the hydrosalpinx.
Is it important to see at the ultrasonography or just see the histosalpingography? Which one is important? Sometimes you can see at the HCC, but not the ultrasonography.
In ultrasound, it's more meaningful if you see on the ultrasound, but if you see on the HCG as well, you need to look inside of the tube. It's because sometimes it's also important. You can just operate the fimbrial side. But when you see on the ultrasound, it's definitely you need to remove or cut.
Do you prefer the salpingectomy or just the ligation?
If she has no surgery before, or if it's possible, I prefer to remove the salpinx, especially to be careful the blood supply of the ovaries.
Another approach, will you prefer to just do it IVF, freeze after that surgery, and use that embryos? Do you prefer that one?
It depends on patient's ovarian reserve, but I do not prefer frozen and thaw cycle. I prefer fresh cycle.
Fresh cycle.
That's why
Surgery, fresh cycle.
Yes,
Right.
I prefer it.
Kubilay?
Actually, the same. We have to remove the hydrosalpinx unilateral or bilateral because there is impending effect of the endometrium, and we have to care about the laparoscopic salpingectomy because of the ovarian reserve just.
Do you use another approach? First frozen cycle, after that surgery, and the TOW cycle?
Actually, it depends on the reserved patient and also the age. Otherwise, we prefer to use fresh cycle.
In your practice, do you use ligation, bilateral ligation, or something like that instead of
If it is possible to reach, we prefer to salpingectomy, but it is not possible, ligate.
For the monolateral hydrosalpinx, do you prefer just one cycle, or just do you prefer directly surgery?
Sorry, I couldn't answer.
For the she has just one hydrosalpinx,
Yeah, one to-
on other side. Do you prefer directly IVF, or first you prefer the surgery, after that IVF?
It depends on the occurrence of the ultrasound, also very important. It depends on the patient's age and also ovarian reserve again. If we have time enough, I prefer to the first cycle and then go the IVF and freeze the...
If it is fail, you will prefer surgery, right?
Yeah.
Okay. Ümit, how about these questions?
Okay, one by one. Definitely we should do some sort of obliteration of the tubes or tube. It can be either ligation or salpingectomy, but in our unit we prefer to do ligation. We don't use aspiration. It's another method that we can use because the fluid accumulation is very quick in approximately 2 weeks, so there's no point to do aspiration. One side or two sides, if it is unilateral, it's not a big problem. You can do it prior to IVF. But there's a debate if it is on each side, there may be a decrease of ovarian reserve that we have to be careful with. So in our unit, we do first IVF and then freeze them all and then do the operation, laparoscopy preferably, and then do the transfer. That's our
This is
strategy.
your routine, right?
Yeah.
Okay.
Thank you.
How about Orvieto in your practice?
First of all, the first question that we have to ask, how hydrosalpinx impair implantation? So is it the backflow of the fluid to the uterus or the inflammatory reaction or response in the tubes that actually interfere with the crosstalk between the embryo and the endometrium, cytokines?
Which one do you believe?
So it's probably both. So that's why actually the best treatment is salpingectomy and not ligation or Assure or whatever. That's for our point of view. Now, and we know that IVF, in the presence of hydrosalpinx, you have a 50% pregnancy rate and twice as much miscarriage rate. So actually the outcome is very detrimental. In Israel, we had this discussion what to do because in Israel IVF is subsidized. So we are actually offering the patient IVF with fresh transfer for at least 2 transfers. When she
before the surgery, right?
Before surgery, and she knows that the pregnancy rate is half and the abortion rate is twice. And if she failed 2 transfer, we are offering the salpingectomy. And you know, there is also the cons against salpingectomy because there is all this data if salpingectomy interfere with ovarian reserve or not. I'm sure that it depends on your surgeon capabilities, but there are studies that showing that if you're doing salpingectomy, the ovarian reserve is decreased. If during the fresh cycle you are doing the IVF and during the OPU you see, sometimes you can see accumulation of fluid intrauterine. So in this case, we are not transferring, not aspirating and transferring. We are cryopreserving all the embryos, and this is an indication to salpingectomy, and then repeat transfer.
Do you use aspiration in practice?
No
aspiration.
I said, no, even
Tubal ligation?
No.
No.
You prefer tubal ligation. You are doing only if there is when the surgeon cannot do the salpingectomy. It's not feasible.
If she has bilateral hydrosalpinx, do you prefer IVF procedure first or surgery?
Again,
Again?
we are offering her IVF For
She has bilateral.
bilateral, if the hydrosalping is such that is not interfering with the ovum pickup. If you're not, sometimes you have to go through the hydrosalpings in order to pick the oocytes. So in this case, we send it to salpingectomy. But if the ovaries are accessible to ovum pickup, so we are doing IVF, doing trial of transfer, and if she's not pregnant, so we are offering a salpingectomy.
Marcus, do you have addition as a last point?
I'm not very expert on salpingectomy, as you can imagine, but what I have seen of the doctors is that there is not a regular plan. Some of the salpingectomies are overcome and they do the cycle. It's decided by the doctor.
Before the IVF, right?
Depending on the diagnosis, we do a lot of salpingectomy. I mean, we don't do ligation or aspiration, as far as I know, in the last years, what I have seen. But also, I have seen that we have done cycles to patients with already anhydrosalpinx, and some of them we do not, because the doctor decides to do further salpingectomy, depending also in the evaluation of the level of the disease of the hydrosalpinx.
Okay. To the audience, she has 32 years old. She is normal. Only she has one lateral hydrosalpinx. Do you perform the IVF procedure or do you perform the surgery? Who perform the surgery directly? Most of them. How about the IVF? Just a few. Okay, thank you. Okay, another approach to the obesity, which is very famous nowadays. Ercan, what do you think about that one? What is the cutoff level to enter the IVF cycle or not?
Above the 30% or 30 BMI.
30?
30, yes. It's decreased the chance of pregnancy, and also the obesity is a main issue of male factor, sperm factor as well. We should consult both male and female to decrease their weight, not just the female. And we need to give them options how to lose weight, like choosing dietaria, or if she needs bariatric surgery. But we need to offer them to decrease their weight.
Before the IVF, what do you suggest to patient to lose the weight? Just diet and exercise, and how about the metformin? Do you use routinely metformin in these patients before the procedure?
No, not directly. We usually consult them with the endocrinologist, and we need to look their needs. But we do not recommend routinely metformin.
Is there a difference between the obesity patients? Most of them has PCO, some of them not PCO, but obesity. Do you have any different approach for this one, for the PCO patients and the not the PCO?
PCO patients cannot lose weight easily. That's why it's hard to give them advice. But the other, without PCO, it's easy to lose weight, and you can have time to start IVF.
Do you have any cutoff level the couple cannot go to the IVF procedure? For example, BMI level is the 40 or 35.
In my clinic practice, I don't have upper limits, but I always consult them with the decreasing chance of pregnancy. And also we consult them with the anesthesiology, because if we start the IVF, they need to have oocyte pickup, and it has also some drawbacks. That's why, but I don't have actually upper limits of BMI.
No upper limit.
Yeah.
Kubilay? For the obesity?
Actually, it is very difficult to answer, because the patient preference is very important. It is very difficult for these patients before coming us to weight loss, and they decide, and after they come in front of us. And of course, there are many options to suggest them bariatric surgery or medical medications or some suggestion, but I think it doesn't work mostly. And many of them come back again with the same obesity level. And the most highest patient maybe that I'm treated is 140 kilograms undergoing the IVF and ended with delivery. But of course, these are very difficult patients for motivations.
Ümit?
Yes, obesity is a big concern for assisted reproductive techniques. It affects oocyte quality and embryo quality. There's a term, lipotoxicity, which is very important, which increase the reactive oxygen species so that the gametes can be affected. So it not only affects women, but also affects men. Definitely we suggest losing weight to the patient, but it's very difficult for such patients. To your question, if there's a limit, cutoff limit, we use 40 as a cutoff limit for BMI. And for bariatric surgery, we should keep in mind that there are some papers saying concerns on stillbirths and pregnancy losses afterwards. So we should be very careful for bariatric surgery. And we should also tell the patient it is important not for achieving pregnancy, but also important for having a healthy baby during the pregnancy period. So that's what we do.
Orvieto,
Obesity.
do you have do you have a big problem in your country?
No.
Obesity?
No.
No big problem.
Problem is in the other side of the Atlantics. When you're looking at obesity and IVF, so obese patient require more gonadotropin. The duration of stimulation is higher. When the HCG is you are actually enough. 1 ampulse of 250 microgram is enough to induce final follicular maturation. And this is significant. But when you're looking at oocyte quality, embryo quality, and receptivity, there's a trend toward the detrimental effect of obesity, but it's not, still there are many studies showing that same oocytes quality, same embryo quality, and even the EV group had 2 studies on obesity and receptivity. In one study, they showed that there is no effect of obesity on receptivity. And the other study, I think the latest one, they showed some trend toward the lower pregnancy receptivity rate in the obese patient. At the end of the day, obese patients do less in terms of pregnancy and delivery rate than non-obese patient. And we looked at this patient and tried to differentiate who is the patient who had the worst prognosis, obese patient or no, they had the best prognosis, because there are many obese patients, specifically in the state, that conceive spontaneously, deliver, and everything is okay. And there is no more congenital anomalies. There are more congenital anomalies, but still there are many normal babies. So when we stratified the patient according to the ovarian response, we saw that the worst prognosis is in obese patient, obese is BMI more than 30, that are poor responders. So those with low AMH or low antral follicle count, and I'm not speaking about PCO now, I'm speaking about obese without PCOS. This patient had the worst prognosis, and this patient should reduce weight before embarking on treatment, because otherwise they won't conceive. The problem is what happens when a patient is coming to you and she is 40 or 42 years old, so you are sending her to reduce weight. At the end of the day, nobody will reduce weight, but 10% maybe will come with the targeted weight that you are giving to them. Most of them will not. So you probably will have to try to stimulate them to pick up what you can pick up, cryopreserve, and then see what's happened later if she will reduce weight. Regarding bariatric surgery, in our unit, the cutoff is 40. We're not treating patients with more than 40, BMI higher than 40, because 40 is a disease. Patient more than 40 should be referred to bariatric treatment, or 35 and diabetes or hypertension should be referred to bariatric surgery. That's the indication, because they are sick. They are sick. Metabolic syndrome is a very silent killer. So we're not treating this patient, but again, sending them to bariatric surgery, you have to wait at least 6 to 12 months after the bariatric surgery to embark again on IVF. So in this case, you have to stimulate the patient, cryopreserve the ovary, send them to bariatric surgery, and then continue IVF.
IVF. Marcus, do you believe obesity has an effect on oocyte quality?
Well, we have done a couple of studies on that we published a couple of years ago, and we were unable to see any clear relationship between BMI and embryo quality. which is the only way to evaluate oocyte quality. So from our point of view, in our practice, normally the problem is with patients with more than 30 in BMI. Well, normally is more recognized. We don't have this big problem in Spain, luckily for us, so the proportion of patients over 30 are quite low. And we have done a program of personal trainer and a dietist for those patients that are interested in losing weight. Although, as Raoul was telling, the proportion of patients that at the end of the history lose weight is very low. It's around 10–50%. So it's unsuccessful. So at the end, we treat those patients too, with more than 30, with some limits, like more than 35 or even 40, which is really a big disease. But I mean, we try to offer to the patients to lose weight, to try to improve the outcome, even that is very difficult. But from a laboratory point of view, we haven't seen any clear relationship between BMI and embryo quality at all.
Regarding the laboratory, there is a very curious, there's two studies from Rakowski group in Harvard and from Boston, and they showed in one study that there is no influence of patient weight on the morphological embryology, and in the other study they showed that the alignment of the chromosomes was worse in the obese patients. So even in the same group, there are different opinions.
Okay, so time is going. We have to be hurry. Orvieto, do you use AHM level in routine practice for each patient?
No.
No. Ümit?
We are not using AMH. You know, we have to pay for AMH in Israel, so we're not using AMH. We're using AFC.
For the detection of the ovarian reserve, do you use the antral follicle or FSH or
Antral follicle.
nothing?
Sometimes we are using AMH, but most of the practice is to use AFC.
AFC. Okay. Ümit?
Not as a routine, but we definitely consider antral follicle counts, especially at the start of the cycle.
Kubilay?
Same. We don't use
Same.
routinely,
Not for
but,
each
just
every patient.
oocyte freezing patients because it's necessary in Turkey for legislation.
Ercan?
Same.
The same, not for each patient. For the evaluation of the cavity, do you use, Ercan, starts from you, do you use routine hysterosalpingography or the routine office hysteroscopy before the IVF?
Before IVF, I prefer to have ACG and also
Routinely?
Routinely, yes. If I have 3D ultrasound transvaginally, I prefer to use it. I do not routinely use hysteroscopy, office hysteroscopy. According to the INSIGHT trial, the RCT, it doesn't have any additional benefit. That's why we do not routinely use. If it's the ultrasound is normal, we do not use.
Kubilay?
We decide according to male sperm analysis. In the first examination, we use two-dimensional transvaginal ultrasound combined with the sono hysterography in all patients routinely during the mock transfer. And it's just if the male factor infertility is the reason for infertility, that's enough for us. But if it is the normal, of course, we have to do hysterosalpingography.
You don't use it routinely?
We don't use it.
Either hysterography or hysteroscopy?
No.
You don't use it?
No, we just use the sonohysterography.
Sonography. Ümit?
Not as a routine, I mean hysteroscopy, but definitely we use hysteroscopy for patients with recurrent implantation failure because according to the literature, there is approximately 14–15% unsuspected intracavitary lesions. That's why we are doing for such patients.
For before IVF, you don't use the
Not
regularly?
as a routine.
Okay. Orvieto?
Usually most of the unexplained infertile patient already underwent HSG, hysterosalpingography, before being treated with gonadotropin. So if in these cases of failed COH-IUI, usually we are starting IVF without any uterine evaluation. And again, after 2 or 3 failure, we are doing the hysteroscopy with or without PPL, depends.
Do you use the hysteroscopy before? Office hysteroscopy? No,
Office
you don't use
hysteroscopy after 2 or 3 failure.
No,
those
I mean
who had the
before
normal
IVF.
hysterosalpingography. In those who doesn't, so we should consider it individually. If there is anything in the history that needs evaluation, so we're doing hysteroscopy. Otherwise, we can start IVF and then see. Depends. If everything is okay, so after 2 failure or 3 failure, we are doing hysteroscopy.
Marcus, the patient's problem is azoospermia. the female is okay, no problem. Do you suggest, as a lab man, do you suggest diagnostic TISA or do suggest the simultaneous IVF with TISA? Azoospermia.
Procedure is to, when we have a patient diagnosed with azoospermia, is first, I mean, we do not start it, we don't do in parallel, I mean, we don't do fresh biopsy and then use the sperm for the ICSI. We normally...
You would prefer simultaneous IVF plus?
We do before the procedure, we do the biopsy.
Biopsy?
We do
Diagnostic biopsy?
No, not, well, I mean, when an azoospermia is diagnosed, we just do the biopsy and if we observe a sperm, we just freeze and do the cycle. We don't do diagnostic biopsy.
After that, you can do it IVF, right?
Yes, we froze always. I mean, it's very unusual to do I mean, once the azoospermia is diagnosed and we go to the testicle, we normally go to the testicle. We don't do aspiration in the epididymis. We always go to the testicle. And normally, unless that is impossible, we try to do first the biopsy, the testicular biopsy. And if we are able to find sperm, then we prepare the IVF cycle.
Regularly for each patient, or do you use sometimes simultaneously IVF plus micro-TC?
No.
No.
No, never.
First?
First micro-TC or
Okay.
TC, depends.
Okay, never.
And then
Okay.
the cycle.
Ercan?
According to literature, if your laboratory is capable of freezing sperm in a good condition, you can choose both, but we prefer to use simultaneously IVF cycle. But also the couple's approach is also important because some female doesn't want to use gonadotropin injection. At that situation, we prefer to use the diagnostic test.
Kubilay?
First, we consult the patients, and we offer two diagnostic and also the conventional simultaneous test, and their advantages and disadvantages. And the patient's preference, according to patient preference, we go the treatment, but mostly we use simultaneous test because in some cases with diagnostic test, if we find very few spermatozoa, and after towing, if we couldn't find them, maybe the last chance of the patients will be less. So the patient must know this. Of course, the diagnostic test is best for the patient in view of the, if you look at the cost. But when we go together with the simultaneous test, and if you find enough, a few spermatozoa, we can also carry the ICSI, and maybe the patients use their last chance in a good way. Before test set to do biopsy is very discussable thing because there is sometimes very severe hypospermatogenesis or focal spermatogenesis, and after the biopsy, if you say there is no sperm, you don't have to test it, and if you find sperm, you can freeze. You have to decide this. Currently, I believe there is no place in the biopsy in the azoospermic patients because there is just one predictive thing. If you find spermatozoa or not, it is the test itself. Otherwise, we don't say anything because there is no any predictive value that proved up to the date that we find spermatozoa or not.
You prefer simultaneously, as I understand. Ümit? Shortly.
There is no role for biopsy, definitely. But in terms of TESE or TESA, whatever, for obtaining the sperm, we prefer to do it prior to IVF because sometimes we cannot find any sperm. So instead of giving lots of drugs to the lady, we prefer to get the sperm first and then do the IVF. That's our policy.
Orvieto?
We are usually doing simultaneously.
Simultaneously.
The male is undergoing TESA in the morning and the female won't pick up later. But that's in cases that they accept to use a donor backup.
Donor
backups. Today,
you have the permission for donor,
we're
right?
doing it even without the donor backup because we can vitrify the oocytes in the new era. Only if they don't want to use the donor backup and they want only, so we are splitting the procedure. But most of our TESA procedures are done simultaneously with the ovum pickup. In the cases because when there is very, very few sperms from spermatozoa, you can't find them after freezing. So
You have the permission for the donor, right?
what?
You have the permission for the donor, right?
You have to?
Permission.
Yeah, we have.
Yes.
Yeah, we are
Okay.
asking them.
Allowed. Okay.
Yeah, we are using donor.
Okay. Who preferred diagnostic test before IVF? Diagnostic test. Just a few. Thank you. The last question about this section, which is very, very important. She has 4 miscarriage before. There is no other things. Everything looks like normal. And do you do IVF procedure for this one? If you do you use the routine PGS for this patient? Orvieto, from you. I sent this question. Yes.
If I'm doing IVM, no.
Do you do IVF?
No, IVM or IVF? I didn't.
IVF. Do you do IVF procedure for this patient?
Patient with repeated.
She has 4 miscarriage in the past, and
Okay.
everything looks like normal.
And do I
She
do
comes to
offer
your office?
IVF with PGS? The answer is no, because actually there is no one study that I'm aware of that looked at intention to treat.
Do
As
you do
a-
IVF this patient? Do you do IVF?
IVF to repeated.
IVF for this patient. Do you do
patient
IVF?
with repeated pregnancy
Unexplained
loss.
recurrent pregnancy loss. Yes.
If the product of conception are aneuploid, yes, and we offer also PGD.
Do you do
But
PGD?
if the product of conception is aneuploid,
If not,
otherwise, we are treating her with control of hyperstimulation and IUI, trying to support more with dufaston, HCG, yes or not.
she has no problem with the fertility.
I know, but with repeated pregnancy loss, sometimes we are offering IVF, trying to transfer blastocysts,
Yeah.
aiming to decrease pregnancy loss. That's what we are doing, but it's very, very few cases each year. I can tell you that we are doing it in 2 cases out of 1,100 cycles a year, first cycle a year.
Okay, Ümit?
If there is nothing else, we do IVF with PGS.
Kubilay?
Actually, we don't recommend IVF and we don't use PGS in these patients.
If the couple doesn't have anything, we offer IVF, but with the PGS.
Offer IVF with the PGS for this couple.
Yes.
Marcus, what do you think about that? Do you think for this patient PGS is useful?
Well, we are now in a world in which the PGS is growing a lot, and now even many clinics are thinking in offering to all the patients. So keeping in mind that, which I'm not fully agree by far, but for example in Spain, which is regulated and we cannot do PGS to all our patients, there's an option to do it when the patient has more than 2 or more miscarriages. So it's an indication to do PGS. Even that is true that probably the results, it depends on the studies, are not completely convincible. It's true also that for our point of view, or for the doctor, trying to offer an alternative to the patient that has done already 2 cycles with a miscarriage is an option to them, and we normally do. When there is 2 consecutive miscarriages, we offer PGS.
Okay.
I want to remark, I'm offering PGD, not PGS.
PGS.
No PGS, PGD. Because
Why?
I said, if the product of conception during the abortion are aneuploid, so we can offer the PGD. It's diagnostic, it's not screening.
Okay.
PGS, in the last study published in Human Reproduction from the Boston group, showed that there is no benefit using PGS in these cases, and even the time to pregnancy was shorter with spontaneous conception and not with IVF. The cost was probably much lower, and the time to pregnancy was shorter with spontaneous conception and not with IVF PGS.
For the audience, for this question, who did the IVF with PGS or PGD? Who did for this couple? Okay, thank you. Let's speak about a little bit about the lab procedure. Marcus, do you believe time-lapse monitoring is improved our results? We have 2 different patients, normal patients, difficult patients. Do you think it's useful for both of them, none of them? Time-lapse monitoring.
We have not
in
reached,
routine IVF.
with the experience that we have now, we have not reached that answer, okay? For example, in our experience that we do a time-lapse, we apply in about 30% of our patients. We have been applied basically in patients with good prognosis with a good number of embryos, in which the idea was to improve the selection by itself. With time-lapse technology, we have demonstrated two aspects. First one is that we may improve the culture conditions, but also it depends on our way of working. So this has been demonstrated because you keep better culture conditions to the embryos, and we have been unable to weight which is the benefit of that option. And the second one is the selection. We have also demonstrated that we are able to manage better the selection if we compare with the standard morphology, and it's clearly demonstrated. There are 4 randomized controlled trials already done. There is 1 meta-analysis done already, which demonstrates that there is an improvement. But we have not reached the point to know exactly if it's, and in the case of patients, I mean, with low responders, with low number of embryos, the option of selection is impossible, so there's no way to improve that.
Forget literature. In your practice, in IVE,
Yes.
after time-lapse monitoring, did you improve your results, your pregnancy rate, just time-lapse?
We have done a couple of studies, one retrospective, we just take a look to all our data in the oocyte donation program, and we observe an improvement, and then we did a randomized controlled trial in good prognosis patients. That is our only experience. In the real practice, what is happening now is that the doctors normally offer the technology to those patients with a previous failure and trying to offer an alternative to the standard. So we don't use like a routine technique, we use as an alternative. And also behind this is also the cost, which is expensive, by far lower than doing a PGS cycle, because we have calculated the cost of doing a cycle with time-lapse is around 200 euros extra. So it's not a big extra cost. That, by the way, normally we are not charging to our patients to that.
For the normal patient, she is the standard patient, not the difficult one. In the first cycle,
We normally do not offer, unless
not
it's an,
offer.
because also I can tell you that we use time-lapse for a lot of studies, because it's a very good technology for good documentation and analysis. So we do a lot of studies around the technology, not directly related, but around the technology. So most of the patients are in that studies just because of, we use time-lapse because they are on studies.
Okay, Orvieto, do you use the time-lapse in your laboratory?
We're using in a limited numbers. Actually, it's a kind of method to try to improve embryo selection. You should tailor it to the group of patients that had a lot of embryo, and you have to decide which to transfer first. So this is I think that the patient that would benefit from the time lapse. Otherwise, if you have a 43-year-old patient with 2 embryos and you are transferring this embryo, so I can see the benefit of using the time lapse, because we're transferring all of them.
Okay, Ümit, do you use time-lapse?
Not as a routine. Not as a routine.
Do you
We
believe?
have
Do you believe?
time-lapse, obviously. In difficult cases, we discuss with the patient. It costs some money. We have to consider this as well. And I personally do not believe that it affects our results too much. So.
Kubilay, do you use it?
We don't have time
You
lapse,
don't
and
have?
also it is very difficult to say something with Dr. Meseguer because he has very huge
How about your
experience.
sense about
But front of clinicians, yes, theoretically it has some advantage providing the better incubator conditions, and maybe instead of the momentary image to get the observational period and to see what's going on in the incubator is maybe it's better. But the question is that it's a good teaching tool. It must be found in the big maybe clinics like EV or some university clinics. But the question is, it is true to force this kind of incubators of this kind of technologies to do all laboratories, and all laboratories has to be good enough. The question should be this, and we don't use time-lapse because we believe there is some benefits, but there is not enough evidence to use in routine purpose for the investigation of the embryos now.
Another issue, it's expensive, at least in our
It is
country.
very expensive. When you use the time-lapse, as you did ask, we don't know the outcomes for poor responders. if we go to blastocyst, when we reach the blastocyst without PGS or without time-lapse technology, we can have reasonable pregnancy rates also. So according to me, this is now as a teaching tool, and it must be like that now currently.
Okay, Ercan?
It's a new tool, and it hasn't got established algorithms. Last month there was a paper in fertility sterility. There are six algorithms, and none of them superior. And the main issue, in my opinion, it's the culture media, and especially O2 level. It should be maintained under 5%. That's maybe it's also useful for that part of side. We are using it, but not routinely.
Okay. Who has used the routinely time-lapse monitoring in their laboratory? Who has it? Just a few? It's interesting. Okay. Marcus, how about your opinion about the sperm DNA test? Do you think we have to use it for routine or just a difficult case or not?
Well, here also there is a lot of variability. First of all, in the way that you analyze DNA fragmentation. There are several tests available, which is one of the main problems. Initially, when this test appeared, was quite complicated to be done because it should be done with flow cytometry, and many few clinics has a flow cytometer available. So then appear other tests like the allosperm, for example, that you can do in your clinic. And also there is the Cometa side that apparently is relatively more easy, but still you need also it has some complication. So that's one of the questions, that the way that you may analyze DNA fragmentation has a different ways to do it. Some of them too complicated to do by all the clinics, and some of them very simple. And in our case, what we did when we started to use it, we tried to do a quite big analysis in our database, and also to analyze quite a large number of studies of patients with DNA, of sperm samples for DNA fragmentation. And the first thing that we realized that we were unable to find a cutoff value that will tell us that there was a clear diagnosis of high DNA fragmentation. So it was difficult for us to decide what that means, a high level of DNA fragmentation in the sperm. So at the end, what is happening is that we normally do not offer like a routine. We have the test available because even sometimes the patient asks us to do DNA fragmentation. Sometimes also we do the test just when we try to see if there is something abnormal in the sperm quality that maybe we can decide that is related with DNA fragmentation. But the big problem is that even, for example, we have patients with 40% of DNA fragmentation that apparently is high because it's above 20, 30%. Does not mean that there is a linked problem between the levels of DNA fragmentation and the outcome. So the point is we don't have a good or defined cutoff value, so then we cannot offer that test like a diagnosis for our patients because we don't know what is high or what is low in DNA fragmentation.
Orvieto, do you use this kind of tests?
No, we are
tests,
not.
something like this?
We are not, but we are offering Q10 to all our male infertile patients. So we're not doing the test, but offering Q10, antioxidant. That's what we are doing.
That's it.
That's it.
Ümit?
Existing data do not support to use DNA integrity testing in terms of natural pregnancy or IUI or IVF. It doesn't affect the outcome, so we don't use DNA integrity testing. It only helps people convincing, in terms of convincing, for example, quitting the smoking or using antioxidant. That's all. We don't use it.
Kubilay, do you use it?
We don't use, but last year in the Excellence Congress, Dr. Esteves from Brazil suggested to use sperm fragmentation test, just not sperm analysis, as a functional test. It must be included in sperm analysis also. And he suggested not just to use in a sperm test, but also he suggested that in the increased rate of sperm fragmentation, even we have to go to test this, because in this case, nearly 5-fold increased pregnancy rates we can obtain after using the testicular spermatozoa. But of course, there is no data in favor of this, and we have to be careful when evaluating the sperm DNA fragmentation test results, because after the test we couldn't use the sperm. After testing, yes, this sperm has increased the number of DNA fragmentation, but we couldn't use the sperm XC, so it is not valuable according to me.
Ercan?
We don't use routinely. In addition, if you have fertilization failure if your laboratory prefer to use IVF, not the ICSI, you may consider to look at the sperm integrity test. And that situation.
You use some difficult patients, right?
Yes, if the fertilization failure and if you use IVF, not the ICSI.
Marcus, the another problem at the lab, the culture media. I don't know how many product at the market now, maybe 10, maybe, I don't know. Is there any superiority between them? Which one is good? Just don't tell any company name, but do you think sequential or all just one media for all one?
I don't work for any laboratory company, so I mean, I think that all of them are good. So at the end, there are many factors that we may know. For example, in each country, the distribution.
Do you use the same culture media at EV or the different culture media?
Well, we normally like to work with two brands, only not with one.
brands.
Because if one fails, you have the another like a backup. Try
Okay.
to use two is more, sometimes it's more convenient. If you trust only one company and then the supply fails for something, you have a big problem. So at the end, it's a good point to know that the supplier of your media is trustable, so the media is arriving to your clinic in the right conditions. So also this depends on the countries, because there are brands that are doing good management in some countries and not in another, and that's important. But from our point of view, normally all the tests that we have done are good for all the media. I know that there are embryologists, even in my, sorry. I know that there are embryologists even in my country that believe that there are culture media are from first class and others that are second, like low cost and high quality. I'm not really agree with that. It's like a feeling, but there's no demonstration behind. So from my point of view, all the brands are more or less equal and good. And also there is two strategies: change the media on day 3 or not. I mean, use single step or sequential. Even now with that two options, I'm not sure which one is better, but for sure if you use single step, everything is easier. Your life in the lab, you work less, it's cheaper, so there are a lot of advantages behind the single step media.
You always say the same company's product, right? You don't change the...
I mean, we change, it depends. If someone is coming with a new media, we can try and it works, and also the price is important. I mean, in the public and in the private sector, the price is conditioning also the price of the cycle to the patient. So also we might try to find a good price for giving a good media too. Okay. And the other section, we have to discuss a little bit about the ovarian stimulation. And we have the endometriosis patient. The couple has the male factor. They will go to the IVF, but she has 30 years old and she has 4 centimeter endometrioma on one side. What is your position, Orvieto, before IVF?
I'm stimulating her and going to IVF and transfer. I think that nowadays we are no more offering cystectomy before IVF, because we know that if there is something that is detrimental is the ovarian surgery, detrimental to ovarian reserve. So what we are doing, we are actually stimulating the patient and doing IVF and transferring and offering the surgery only after completion of the family planning. That's what we are doing.
You prefer directly IVF, not the surgery, right?
Not surgery.
Not surgery.
She's embarking on IVF because you can also offer a COH-IUI for 1 or 2 cycles, but if she's young and only with endometrioma. Otherwise, we're offering IVF, not surgery. If she has a complex a condition like hydrosalpinx and endometrioma and myoma and so we'll offer surgery. But if it's an isolated endometrioma, 4 or 5, so we are stimulating her and doing IVF.
Okay. Ümit?
Well, short answer, I do follow Turkish Endometriosis Adenomyosis Society guideline. So in this particular patient, I don't touch. I directly go to IVF.
And do you prefer fresh cycle or the frozen cycle?
No. Well, according to the literature, it's better to suppress first, but in our experience, their ovarian reserve is very limited. So what we do, we get the eggs, oocytes first and fertilize them and freeze them all and suppress the endometriosis around 3 months, and afterwards we transfer.
Okay. Orvieto, do you prefer for this patient fresh cycle or frozen cycle for this patient?
First cycle.
Endometriosis patient, she
I
has
think that
endometriosis.
the suppression that she is recommending is important for folliculogenesis, not for receptivity. So the problem in endometriosis is not the receptivity. I think that in all the EV studies with donor, combination of donor with endometriosis and the recipient with endometriosis. So the problem is folliculogenesis. So if you want to offer this long suppression protocol, so you have to offer it because of the folliculogenesis, the effect of endometriosis on the oocyte quality. But otherwise, if there is no detrimental effect on receptivity, so you can transfer. Recently, I think a year ago, there was a very large SART data published in Fertility and Sterility showing that actually endometriosis patients are doing the same as a male factor infertility or male factor patients. So,
Which protocol do you choose, agonist or antagonist?
we used to choose at the old days the long agonist, and we
Long
are
agonist.
still using it. But today you can use antagonists, and so, usually they are on the pill. This patient between the cycles. So if she's enough suppressed with the pill, so we can stop the pill and embark on the antagonist.
You
We get the
prefer
same.
pill plus agonist cycle, right?
They're always on a pill.
On
So
pill.
they're suppressed for more than 1 or 2 or 3 months. So if she is suppressed enough, so you can use the antagonist.
How
Because
about
we are using the
ultra-
antagonist not because of the antagonist, because we can trigger differently with the antagonist.
How about ultra-long protocol? 3 months
Ultra long.
or?
I
Yes,
said we used to do it in the past. We are not doing it anymore.
not anymore.
Not anymore.
Kubilay?
We direct to go IVF without surgery. We prefer antagonist protocol, although there is evidence to extending the GnRH analog.
You prefer agonist protocol?
Yeah, antagonist protocol.
Antagonist protocol.
Yeah, but there is some evidence indicating that the extending the duration of the GnRH analogs better.
Do you use
but-
ultra-long? Do you use ultra-long?
No, because many of our patients coming up outside ST, and so we have to use antagonist protocol.
Do you prefer fresh or frozen cycle?
Fresh cycle.
Fresh cycle. Ercan?
I prefer to use ultra-long protocol, 3 months suppression, because I know...
You mean ultra-long?
Yes. We know the oocyte number of oocytes will be low, but the quality will much better. And that's why, and we prefer to fresh transfer, and frozen will be an option as well.
Ümit?
Just want to add, well, to our personal experience, we have used Dianagest prior to IVF, and what we have seen, it doesn't suppress the ovaries that much. So we are collecting the data now. Instead of using GnRH for the suppression, it might be wise to use Dianagest and afterwards do the IVF and freeze them all. Definitely Dianagest affects endometrium very badly, we know, and freeze them all and then transfer afterwards. It might be a good strategy. That's what we
Another
are
approach.
doing now.
Marcus, do you believe endometriosis itself on effect on oocyte quality? Just endometrium.
Yes,
endometriosis.
definitely yes. I
On
mean,
oocyte,
it depends on
not
the
the
grade,
embryo.
the grade of endometriosis. But I mean, what I see from the lab point of view is that patients with endometriosis normally has worse prognosis than other indications. That surgery is, I see from my point of view, from the lab, that is every time is done less, almost nothing. And I mean, there's nothing else to do. I mean, the patient has endometriosis, we treat them like other type of patients with an infertility diagnosis. That's all.
Orvieto, do we have miracle for the poor responder patient? Do we have miracle drug, miracle ovarian stimulation protocol, which you are using? Please.
You know, the Cochrane review concluded that actually no protocol is as an advantage on the other. I think that each one of us should choose his own protocol according to his experience. What we are doing, we are using the ultra-short antagonist protocol. We are doing the flare, we are using the pills, using the ultra-short agonist with the antagonist protocol. And what
Which one do you prefer, ultra-short agonist or antagonist?
we are combining them both. We are doing
are
the
combining them.
ultra-short with the antagonist. So
Antagonist.
it's 3 days of decapeptyl, FSH,
So-called
and
hybrid protocol. Maybe we can say
Called?
hybrid protocol, hybridization like.
Hybrid, okay.
Okay.
We call it the ultra-short antagonist. So we are giving this protocol to the patient. We found it, with very acceptable outcomes, something like 10 to 15% pregnancy rate in this poor responder patient. And what
You
we are
use the
tailoring,
agonist, sorry, you use the agonist 3 days or how many days?
3
you use?
days.
3 days.
Only for the flare.
Just flare, after that, you can start at the antagonist.
Gonadotropin, and then or flexible or fixed antagonist, both. Agonist at the beginning, antagonist at the end of the cycle,
Okay.
and pills before. It's a kind of micro flare with the antagonist.
Before the cycle, do you use something, estrogen or DEXA or
We
something?
use the pill. We use the pill, anti-androgenic pill.
Just the pill.
The pill, and usually anti-androgenic.
And
Anti-androgenic
androgenic pill used.
We published it in Fertility Sterility with Laufer 2 or 3 years ago, the combination of ultra-short agonist with antagonist following the pills. We're using it in this kind of patient, and what we are doing is tailoring the trigger. Actually, in this patient, we are giving or the dual or the double trigger according to the size of the follicle on the day of trigger.
For the poor responder, right?
For the poor responder, we are actually dual triggering them with HCG, and at the end of the simulation, instead of giving only HCG, we give HCG with decapeptyl, usually 34 hours before, because this patient also suffer from increased risk of premature luteinization. So we are giving the trigger 34 hours before pickup, and in those that have a smaller follicle, let's say 16, 17, so we give the double trigger. We give the decapeptyl 40 hours before and the HCG 34 hours before. We are getting a very nice yield of mature oocytes and good quality embryos.
Clarify it to understand me. Ultra-short protocol, antagonist, double trigger, right?
Double or dual, depend on the size.
Double or dual, okay. Ümit?
We use antagonist protocol. It's wise to use estrogens prior to
How
start.
many days?
7 days would be enough.
How about the
luteal
dosage?
phase.
Dosage.
6 milligrams, valerate. And
This is routine, right? This is your routine.
Yeah.
This is your routine.
Well, not a routine. We always individualize according to the patient. It definitely suppresses luteal gonadotropins, and it helps synchronization very much. We don't use OCs because it suppresses deeply the ovaries. We either use estrogen or use nothing and start antagonist cycle. We use antagonist cycle. We use pooling, definitely, and we sometimes use double stimulation. So stimulation, collecting the eggs, stimulation at the same cycle again, and collecting the eggs again. We sometimes use this protocol.
The new protocol, use the new one.
Yeah.
For the pooling, for what? For PGS?
No, just for pooling to decide which embryo is the best.
Actually, you pull to 6 embryos in 3 cycles.
Right.
What do you do?
I prepare the endometrium and then transfer the best ones.
Without PGD?
No, not really.
Without.
No.
Kubilay?
But beforehand, in such patients, we want to be sure of hysteroscopy because they've got 1 shot to go because of the limited number of embryos. So in those patients, we definitely use hysteroscopy prior to embryo transfer.
Orvieto, do you think this is useful for the patient, for this kind of patient?
In
because
such patients, we've seen this.
Ümit, I am asking Orvieto.
Sorry.
Do you think it is useful because she has no chance, she has just 1 chance, that's why she is doing the office hysteroscopy before the IVF, before transfer? Okay, Kubilay?
I don't use OCP before treatment.
You don't use?
Starting, yeah, just in some cases needing schedulation. And there are some subgroups in poor responder patients. For example, we use antagonist protocol, and mainly the dose of 300 or 317, but some cases the increase of the doses sometimes works to 450, but not 600. And in some cases, the addition of LH, for example, over 35 years old or old kind of patients, it works sometimes. I don't use.
Kubilay, do you use just FSH plus FSH and LH for this kind of patients?
FSH and LH.
LH.
Actually, HMG I use. I prefer the HMG.
Ümit?
Not adding the LH.
Ümit?
FSH and HMG together.
Orvieto for this patient?
FSH from the beginning and HMG when we add
The last days.
the
Okay.
antagonist. Yeah.
Okay. Kubilay, go.
And accumulation of those sites may be an alternative, but as you said, without PGD or PGS, why I don't know, because if you have transferable embryos, I didn't need to make them.
Do you use pool? Do you use pool?
No.
No, you don't use it. Ercan?
We don't use pooling either, and also we use antagonist cycle with the estrogen priming, but we use
At the same dosage, same day, like
not,
the
not
doctor?
as high as Dr. Kubilay's. Our highest number is 300. Sometimes we prefer to use mild stimulation with aromatase inhibitor. Sometimes it works as well.
How many days? Wow, dosage.
For 5 days.
In the first day or second or third day?
We start at the second day.
Like the gonadotropin?
Yes. And we just use for 5 days, twice a day. And also sometimes we use adjuvant therapy as well. We don't know there is enough evidence, but sometimes it helps, like androgens and also growth hormone. But there are no robust data because the dosage and usage time is not very well defined. That's why we sometimes prefer to use growth hormone.
Orvieto, do you use growth hormone in your country? Growth hormone, yes, for these patients, for poor responders.
There are some practitioners that are using it. It's a kind of gimmick, to my opinion, because there is a very nice Australian randomized control study that was published presented in ESHRE, showing that a very large one, showing that actually you are yielding one more oocytes, but at the end of the day, the live birth rate is the same. So why to give an additional medication with a very high cost, and at the end of the day, finishing with the same live birth? So
Do you use letrozole in this kind of patients in your
it's
practice?
not registered in our country.
You don't use it?
Not registered
Not registered?
for infertility treatment.
Okay. Kubilay?
Ask a question, Dr. Orvieto. After OCP, we mainly use 5 days washout period.
2 days.
But after microdose program, we use 2 days. 2 days is enough?
I think the 2 days is the appropriate washout period, because the 5 days, I think that I already discussed it with the EV group on RBM Online when they wrote, Fatemi is here? I saw him. Where is he? Fatemi is not here. So, Valesco and Fatemi wrote this paper, to pill or not to pill, before antagonist trigger. And actually, the answer is you can pill because at the end of the day, with and without oral contraception pre-treatment, the results are the same. And the question is how many days you have to wash out. So the 5 days washout is very old studies done by Yen at the 60s, when they treated patients with 200 to 300 microgram of ethinyl estradiol. 3 to 200 microgram of ethinyl estradiol. It's actually 10 pills a day. And they showed that the FSH peak was 5 days after the last pill. So if it's 5 days after, you want to add your FSH on the same spontaneous FSH peak. And when you are looking, when you have this spontaneous peak after a normal pill, 20 or 30 microgram, so it's 2 days. There's a very nice study by Urain. No, it's a study, but also a paper published in Human Reproduction, I think, in 2004 or something like this, or 5, showing that actually 2 days washout after the pill, it's enough. Because otherwise you have 2 waves of FSH. You have the wave after 2 or 3 days, and then after 5 days, and all the issue of pills and synchronization, you will see that there is no synchronization at the end of the stimulation. If you want your follicle to be synchronized, you have to start the FSH after 2 days washout, and you don't need to wait for the period, the menstruation. Start. We are doing the ultra-short antagonist, and in this case, you have to start 2 days after 2 days of washout, and you need the pills because of the LH.
What about long protocol in poor responder patients? Because why then
Long
for the synchronization
I know.
suggest
Long protocol, if you use it, you have to use the mini dose, meaning that you have to depress the patient, and when you start the stimulation, you have to reduce the dose to half. That's the mini dose protocol. DECA 0.1 and from day 21 until menstruation, and then to reduce the DECA to 0.05. Again, meta-analysis, Cochrane review show that actually same. Also, long protocol, antagonist protocol, ultra short, all yield the same results. And at the end of the day, you have to decide what you are using because it's your experience and your patient, and you know what's good for you.
Ercan, for the normal patient, normal responder, do you prefer agonist or antagonist, or do you prefer ACG trigger or the analog trigger, just ordinary patient?
We mainly use antagonist protocol, and if the response is good enough, we use HCG trigger.
Kubilay?
In normal responder patients, we also use antagonist protocol, but the normal responder patients also may be separated between the 9 to 10 oocytes to 10 to 15 oocytes, and may be managed differently, and maybe some dose increase is necessary, but we use antagonist protocol.
Mostly use ACG, right, for trigger. Ümit?
We use antagonist protocol for normal patients. We use both for triggering, so gonadotropin plus HCG.
ACG. Orvieto for normal responder patient.
I think this is the title of my presentation at 1 o'clock, so if you want to hear my opinion, so in 1 hour you will have a 30-minute talk on this issue.
Okay. The last section, which is very important, according to my knowledge, embryo transfer. We have to discuss a few issues. And Orvieto, do you believe freeze-all for all cycles?
Freeze-all only in cases that you are triggering with agonist and you can't add HCG, small bolus of HCG. In these cases, pregnancy rate decreases, miscarriages increases. In these cases, I prefer to freeze-all. Otherwise, we are transferring at least 1 or 2 oocytes, and then we have a lot of extra plus embryos to freeze. So freeze-all as a Shapiro is trying to push to make one cycle, to freeze-all, and to transfer one by one. So in case that you are stimulating vigorously and the patient is at risk to develop OHSS, so okay, do it. At the end of the day, we'll have the same cumulative pregnancy rate. But I think that still a vigorous stimulation, it's not only OHSS, it's the pain, it's the bleeding, it's torsion, there is a lot of other complications. We are only speaking about vigorous stimulation and OHSS. But there are many other complications that we are not reporting, but they exist.
In your practice, mostly you are prefer the fresh cycle, right? As I understand.
No, we're doing 1,100 fresh cycle and 500 cryo cycle a year.
Okay. Per year,
That's
right?
Not from freeze-all cycle.
Okay. Ümit?
We used both fresh and frozen cycle, but not all to freeze. According to our data, approximately 80% of our cases is frozen cases. So for 20, it was actually 90 last year or more than last year, but we understood that one size doesn't fit to all. We have to consider patient by patient. We have to individualize. So it's not wise, at least to us, to freeze all and do the other work. Instead, patient by patient, we have to discuss and decide what to do. But 80% at the moment we are doing freezing, and the rest is fresh.
8%. Kubilay?
we use freeze-all strategy just for the indications. I mean, if there is OHSS or
Not routinely.
endometrial abnormality, or if we do PGD, not PGS, in that cases. But otherwise, there is no logic now currently to freeze-all strategy, undergo the freeze-all strategy, because we don't know anything about the future. Epigenetics, large for gestational age babies, placenta accreta increased. Just we know the ectopic pregnancy is lowered after the freeze-off strategy. That's all.
She has 2 fresh cycle, embryos are okay, but no pregnancy. Do you prefer for the 3rd cycle, freeze the cycle, or just continue with the fresh one?
No, because in this situation we have to introduce the freeze-off strategy, the treatment of the recurrent pregnancy loss or recurrent implantation failure, but there is no proof now.
Ercan?
We do not routinely use freeze-all. We use fresh cycles. If the indications is obvious, then we will freeze-all.
Freeze-all. Ümit?
In that particular case, there might be some subtle endometrial lesions or adenomyosis, so it's wise to switch to frozen cycle.
Okay. Marcus, in EV, do you prefer freeze-all or just in case?
The proportion of frozen embryo transfer now is around 60%, but that does not mean that we are doing 60%, but that does not mean that we do 60% freeze-all. We do only freeze when there is an indication, as they have pointed the triggering with agonist, obviously. There's an indication for freezing. And together with that, also, of course, in cases of low responders, we used to accumulate and freeze to have a good number of oocytes or embryos. And still is the question of the high progesterone the day of ECG triggering. So also in cases with high progesterone levels, which the cutoff is still a little bit complicated to decide, but around 2 or more, normally we decide to freeze the embryos, and that's all, but not for all patients. And of course, we do a lot of frozen embryo transfer for the surplus embryos in the cases of patients that fail in the fresh one.
For the general speaking, do you prefer for freezing day 2, day 3, day 5, day 6? For just general speaking.
We only work, now we do all blastocysts, so all day 5 or day 6.
You
Not
don't
day
freeze
2.
that cleavage stage?
No, never.
Only just day 5. How about day 6?
Well, I mean, regarding day 5 or day 6, just taking a look to the data that I reviewed a few days ago, the implantation rate of embryo transfer on day 6 compared to day 5 in fresh is around 10% less. And there are studies that potentially say that if you transfer an embryo that is coming from day 5 or day 6 in a frozen embryo cycle, the implantation rate is exactly the same. But in our case, the last time that I reviewed it in our database is not true. I mean, we have lower implantation rate transferring embryos that reach blastocysts on day 6, because those were a delayed blastocyst.
For the thin endometrium, do you add something which is successful for the patients? She has always thin endometrium. She has 4 hysteroscopy. There is nothing there. But do you do for the next cycle something to add the...
You know, I published a review 4 or 5 years ago on thin endometrium resistant to treatment. I think that the conclusion is that she needs a surrogacy. But there is many manipulation that some may have some benefit, others not. You may stimulate with the long protocol with low dose of estrogen. That's one kind of treatment. So that the endogenous estradiol probably will improve endometrial growth more than the exogenous estradiol. And there is all this new treatment, yes, GCSF, no GCSF, vitamin, Viagra, all this treatment. But I think that the studies are very small.
It's useless,
and
right?
they are not, no. There is no one good treatment.
Ümit, shortly, anything for the
Yeah,
thin
in thin endometriosis, we do use some sort of supplementation. Definitely, we increase the dose of estrogen, and we use differently patch or intravaginal form. And also, CSF, to our experience, seems promising, really. But it's debatable. We don't routinely use sildenafil.
Do you use CSFs?
Yes.
Yes. Kubilay?
We also add some drugs for supplementation, but there is no proof. None of them is working.
Ercan?
In the beginning, we were adding GSF, but according to Gleicher paper, case series, it was 4 cases. And then he published that it doesn't work, and nowadays we just increase the estrogen dosage. Otherwise, there is no cure for the thin endometrium.
Okay, I finished my question. For the topics that we have discussed, we can get 3 questions because time is limited. Only 3 questions to the panelists. Would you like to ask something? No question? Just one, please. Biraz hızlı hareket edelim arkadaşlar.
My question is about pooling procedure. Is there pooling? I mean, pooling the embryos. Is there really any conceivable explanation for pooling the embryos if we will not do PGS? I mean, what's the rationale?
Okay. Any answer?
I think that the question is not to me because I don't believe in PGS. I'm a big proponent of PGS and specifically in poor responder patients, so maybe they will want to...
You mean accumulate embryos? I mean, to have a good number until prior to do the analysis or to perform the transfer, you mean?
Without PGS, right? Without PGS. Yes. Ümit?
I think the question came to me. Well, with pooling, you have got just 1 or 2 oocytes at each cycle, so you're pooling them as embryo. But definitely it is debatable, but this is our opinion, this is our view. If we do PGS, then there might be mosaicism, which concerns us a lot. That's why instead of doing PGS, we routinely choose the best embryos and transfer to the lady. It is debatable, you're right.
Ercan?
In my opinion, without PGS or PGD, pooling is just for couples not drop out the treatment cycle. That's why there is no rationale about in my opinion, pooling.
Okay. And thank you. Just another question. Thank you. Another question, please. Doctor? After this panel, we have very important guest from Germany. He will talk about endometriosis medical management. Please stay in here with us. Please.
As Dr. Ercan mentioned, according to the fast-track trial, there is no added value in gonadotropin plus IUI cycles. My question about PCO patients. According to our Turkish security institution, they provide 10,000 units of gonadotropin for 6 cycles of IUI stimulations. And at the end of the day, if you don't have any dominant follicles or cycle cancellations, all of these high dosages of gonadotropins become a trash. And after you pass to IVF, and at this time, only 3 cycles per 3,000 units of FSH are paid. So can we adapt the conclusions of fast-track trial also for PCO patients? First line, clomiphene or letrozole, then directly pass to IVF. Is it more logical than unexplained?
This is not our subject. This is the Ministry of Health rule. We can discuss at the outside. This is not our subject. You are right? This is not our subject. Another question? Dr. Özay? The last question.
Thank you. I want to ask hydrosalpinx. Are the micro inserts like Assure or Adiana abundant? Is it out for the blocking, corneal blocking.
Did you understand the question?
Thank you.
He's asking
Yes,
about what
Assure.
is the role of the Assure for the prevention of the hydrosalpinx.
We offer the Assure, we published it. We offer the Assure to patients with hydrosalpinx that they are unoperable, that you can do a laparoscopy because there are a lot of adhesion or they are medically high risk for operation. And there are, as you know, reports on pregnancies that ended with normal births. I don't know what's happened, but during the last year, the company is not anymore, there is no Assure in Israel. So I don't know how can you use Assure, but, and another issue who is introducing the Assure, because it's a different introduction when you are using Assure in patients that want to conceive, because Assure is for actually contraception, so you have to insert the Assure very deeply so that it won't interfere with implantation.
Yes, just short.
We do have some experience with Assure, but it's difficult to find in our country, perhaps you know. It should be taken from outside and patients should take it, bring it anyway. But we have got the similar results. So Assure is not abundant. However, it's very difficult to find it at the moment. If you find it, you can use it as an alternative.
Okay, now we are closing the panel. We will continue with the medical management of endometriosis. We have the lunch on the next door. You can take it, and we will start in 5 minutes. Thank you so much.